Welcome. Hi, everybody, for this very special episode on MIGS to Max. Let's talk about glaucoma today. And more importantly, let's actually introduce this plethora of experts that we have on board to kind of take us through this journey. But before we go ahead, I wanted to introduce the Rising Star series as it. I'd like to tell you a little bit about the Rising Star series. It's a 9 episode series, and each episode features one rising star surrounded by 3 celebrity panelists. By celebrity panelists, I'm not talking about those celebrities which are followed by paparazzis and stuff. Sorry for the disappointment. But we're talking about the real heroes in the field of ophthalmology who take us through experts and who take us through their expertise and educate us. This is an interactive series, so any audience member watching can always throw in their questions in the chat window in our website and a YouTube channel. But we're live on risingeyestars.com and on our YouTube channel, Rising Stars in Ophthalmology. So all the reruns, because it's a global event, all the reruns can be watched on our website. Also, please watch out for the social media handles on Facebook, Twitter, LinkedIn, Instagram, because a lot of the educational tips and snippets, smaller pieces of it, are always going to be put up on our social media platform. I'd really like to thank you guys for tuning in and thank our sponsors for making this happen. And it's not possible without them. Now, to do the honors, I would like to call upon Jennifer Lowe, who's going to introduce our celebrity panel and our speakers. Jen, all of you.
Thank you so much, Ashwin. And as always, it's such an honor and pleasure to co-moderate with you and to get to meet with all of our celebrity panelists and our wonderful rising stars. First off, though, I would like to thank our season 2 sponsors. Really, without their support, we would not be able to actually run this series. And we really want to thank them. Every episode, we want to thank Allergan, Alcon, Vices Therapeutics, Avellino, Dompe, Sun, and Tarsus. But especially for tonight's episode, I would like to introduce Dr. Randy Craven, who will be speaking on behalf of Allergan tonight for a few minutes. Dr. Craven, take it away.
Thank you very much. And I'm excited to be here this evening with everyone. And good evening. I hope you're all doing well. I thought I'd just update you a little bit about Allergan, which is now an AbbVie company, a little bit, and also tell you the story as to why I came over to Allergan. I've been involved with clinical research for nearly 30 years. I came to Allergan in the late 1980s, was involved with a lot of their neuroprotective trials that they tried to develop in the 90s, believe it or not, as well as some of the other developing drugs, which I've had the fortunate opportunity to work with over the years. But many years ago, actually it's been over 10 years ago now, I was approached by some of the clinical researchers at Allergan at the time, and they asked me to take a look at a product that they were trying to develop, which was a sustained release form of bimatoprost. And we went into the lab and I looked at all of their preliminary data that they had as far as safety and what they were working on and what appeared to be the efficacy in animals. And I said, this looks like it's going to be something of good potential. So over the years, Rick Lewis and I were the first 2 people that really started to work with sustained release and drug delivery for glaucoma. And we participated in the phase 1 and 2 clinical trials, and I participated in the phase 3, both in the United States and out of the United States in Saudi Arabia when I went over as the chief of glaucoma there. But the thing that really became apparent to me was when I started to use it in different circumstances, how patients really were clamoring or dying to have some kind of a sustained release product. Allergan came to me last year while I was at Johns Hopkins and said, we really need somebody to help us lead our medical side of the company into the new era of what we see as things are changing, especially with AbbVie's interest in trying to develop a global platform of technology as well as new products for glaucoma. So we're still continuing to work with new sustained release delivery devices. And Durista has already exceeded in this last month where we thought it would be since its launch. Launch was a little bit rocky through the COVID era. But really, the people are starting to see the indications for it. Many people are starting to tell me about the patients they've had success with and how happy they've been with using it, which I think has been encouraging. But I look forward to what we're going to have in the future with other products that are coming down the line and are in development right now related to sustained delivery. And I think that the future is bright for our ability to have drug delivery options. And I'm really glad to be here to help sponsor this program because I think it's much needed for us in ophthalmology. Thank you.
Great. Thank you so much, Dr. Craven. It's wonderful to hear your story and an honor to be part of the exciting times of Durista. So I'd like to first also, before again we launch into our amazing episode, I would like to introduce our speaker and our celebrity panelist. And as everyone knows, tonight is episode 8. And we will be discussing MIGS to the max. Pretty exciting title. So first up, I would like to introduce Dr. Cathleen McCabe, and a little bit about Dr. McCabe is she went to college at the Florida Institute of Technology, medical school at Wisconsin, residency in Bascom Palmer Eye Institute, and she did a fellowship in life, which is pretty important and educational. She is currently the Chief Medical Officer at Eye Health America and the Medical Director for the Eye Associates. Fun fact about Dr. McCabe, she has a black belt in Taekwondo, and she's also a marine biologist and studied sea turtles. And she took a submersible to 2,600 feet. Is that a submarine or what is a submersible?
Yeah, it's a device like a submarine, except that it's for research purposes. So,
okay, yeah. That's very cool.
Gets you down deep.
Yes, definitely can tell that. Awesome.
What was your IOP
down? Back in that day, I wasn't worried about IOPs. Probably pretty high.
That was probably a good thing. Okay, so next up we have Dr. Nathan Radcliffe, and he went to college and at Colby College in Waterville, medical school at the Temple University School of Medicine, residency at New York University, and a fellowship of New York Eye and Ear Infirmary. He is currently at the Advanced Microincisional Glaucoma Surgery Center at the New York Eye and Ear Infirmary, and is also on faculty at Mount Sinai Hospital. Fun fact about Dr. Radcliffe, he kind of liked being quarantined for COVID, I think is what this picture is showing. Am I correct?
Yeah.
Okay.
That's absolutely right. Me and my guitar.
Got it. That's what I was interpreting that photo as. Okay, and last up but not least, we have Dr. Douglas Rhee. He did college at the University of Michigan, medical school at the University of Michigan, residency at Wills Eye Hospital, and fellowship at Bascom Palmer. His current position, he is the professor and chair at Case Western Reserve University. And a fun fact about Dr. Rhee, and I may have to have him explain this for a second, but he discovered the importance of SPARC, which was discovered thanks to an embargo by the UK on cats. So what did the UK have against cats, Dr. Rhee?
Well, I was all set and ready to do a clinical fellowship in London, but because they have a quarantine of 6 months and we couldn't put our cat anywhere else, I actually switched plans and ended up doing lab research at the NIH, and that changed my career.
Wow, that's really cool. Yeah, you never know what's a good or bad thing, right? So that was great. I guess that happened. Awesome. Okay, well, to introduce our rising star tonight, many of you already know her, but we have the wonderful Dr. Sahar Bedrood. She was born in Iran and immigrated to the US at age 3 and did undergrad at UCLA and medical school, not only an MD, but also a PhD at the Keck School of Medicine. And obviously here's a picture of her beautiful family, and I'm going to move slides and let her take over to showcase some of her photos and tell us a little bit about herself. So.
Thank you so much. So yes, you started that introduction perfectly. I went to undergrad at UCLA, went to USC for medical school. I stayed at Doheny/USC for residency, and I graduated there to 2015. I thought that maybe residency wasn't hard enough, so I decided to have a baby during residency. But in all honesty, I especially at Doheny, LA County Hospital, right? No, but in all honesty, I just truly believe that, you know, women, we can do this. We can have babies whenever we feel like we want to, and so I did, and that's my beautiful daughter, and that's me in scrubs. I really didn't think I saw her for the first year, but hopefully she's not traumatized by that. You can go to the next slide.
Sure.
So I wanted a little bit more excitement. And so I decided to move my 18-month-old at that point to do my amazing fellowship at Wilmer Eye Institute at Johns Hopkins. It was a once-in-a-lifetime opportunity, so I kind of made that leap. I lived in Los Angeles, obviously, at that time, and then I moved over. My husband was working out of the New York office of his firm, and I was in Baltimore with my 18-month-old. And here's this amazing faculty that I got to work with during that year. I did over 300 primary cases at Wilmer and did a ton of trabeculectomies with Harry Quigley, who you can see I'm operating with on that side. And I think you can switch the slides, because it was not all serious. We did all kinds of fun things. This is Henry Jampel, and this is Harry Quigley, but we did a spinning for charity competition type thing together during that year. And then this is Harry Quigley with my daughter. He was taking care of her while we were doing journal club because I had nowhere to put her. So I brought her with me, and he really likes children, turns out. So it wasn't all serious trabeculectomy work during that time. I think you can go to the next slide. So yes, after that, I actually joined an academic position at USC. I was there for a couple of years, and then I joined private practice. And now I just am transitioning out of my current practice and joining Advanced Vision Care, which is Nicole Fram's practice in Los Angeles. And I'm really, really excited about that. It's going to be a new chapter for me. And here are pictures of my kids. So you can see we had a fire truck birthday party for my then 3-year-old. My kids are now 8 and 5. We spend most of the weekends having as much fun as possible and eating an exorbitant amount of ice cream. And I'm enjoying it until it lasts, until I have no more excuses to eat ice cream all day long. So that's that. I think that's all I have. I don't know if I have any more slides, but for that.
Well, thank you for the beautiful interview. Or the beautiful introduction about yourself. And it's definitely an honor to have you tonight. So we can't wait to hear your presentation.
Thank you. So I guess I can share my screen now, and so excited to have this opportunity to talk to you guys, to the panel members. What a treat. All right, so my talk will be about MIGS. I am basically going to be talking, I'm trying to make it a little bit more discussion based. So I'll be going through a case and kind of talking through it with you guys. These are my financial disclosures. As an overview of what I'm going to present, I'm going to talk a little bit about patient selection. Then I'll go through my own personal algorithm and my surgical decision making. Talk a little bit about troubleshooting in MIGS as I go through the cases and get your input on that. And then discuss a little bit about the future of MIGS. When we think about MIGS, we define it as minimally invasive glaucoma surgery. It's thought to be lower risk surgical intervention. Treatment occurs earlier in disease than traditional trabeculectomies or tubes. It's generally thought to have a higher safety profile and can oftentimes have lower efficacy than traditional surgery. Kind of tell my patients that in MIGS, it's low risk, sometimes low yield, but not always. A lot of the MIGS surgery we do is quite successful, especially if you're implementing it earlier in the disease process. Some people define MIGS as not touching the conjunctiva. That's not really in my definition, and you'll see that as you see how I do Zens. And as we know, there are 3 different pathways to implement MIGS surgically. First is through the angle. So basically allowing more flow through the physiological outflow for the trabecular meshwork, as you can see in number 1. The second is suprachoroidal space. We don't have anything on the market right now for that, but that was what CyPass was. And then the subconj space, which is basically Zen, which is the only thing on the market right now, and PreserFlow, which may be coming out soon. And then we talk about the algorithm, the when do we do what when. So let's talk about that. When I look at open angle glaucoma, I think about mild disease versus advanced. And in mild disease, I then branch it out into phakic with a cataract that I want to take out, or IOL or no cataract. In the phakic cases, I will take out their cataract. If they have mild disease, even if they're not progressing, if they are on a couple of drops, if they have RNFL thinning, I will try to implement something to encourage drainage through the angle. And that can be in the way of iStent, Hydrus. I often do ECP for a lot of my angle closure cases, KDB, Omni. I don't do trabectome, but that's kind of another angle option in this case. If I don't have a cataract, then I kind of switch over, and you can still do angle procedures such as Omni or GAT, trabectome, and I can still do Zen actually in these cases if they're kind of in the more moderate range. And then you move over to the more advanced cases. I have to move my bar because it's blocking it. So the advanced cases, it's very similar actually. Phakic with a cataract, you can do cataract surgery, implement any of the MIGS devices, excluding iStent and Hydrus because that's not really considered appropriate for advanced cases, or continue on. If you don't have an IOL, I will typically do Zen in these cases. I have done Omni and KDB as well. All right, things to consider, factors to consider. Phakic versus pseudophakic. I already talked about that. If I'm taking a cataract out, I will implement some kind of MIGS or angle procedure. Open versus angle closure. Primary surgery versus refractory. That's going to change the way that I decide what to do. Scarred versus a pristine conjunctiva. If it's scarred, it's going to be kind of prone to more scarring later on, even if I have to do a Zen, for example. Prior history of laser trabeculoplasty. So if they were successful with SLT, they may be successful with angle surgery. IOP, number of medications, and then demographics. All of these are taken into consideration when I decide what surgery to do. Other miscellaneous factors that I really like to think about. When I look at the angle, I think about how much am I going to get this pressure down by doing angle surgery? Trabecular angle procedures might not benefit people with elevated EVP. So who are those people? People with scleral buckles, people with Sturge-Weber. It's not very common. People with thyroid eye disease, but it's still something to put into your consideration when you're thinking about it. There's only so much you're going to be able to do for those patients. People with bleeding disorders might not be good candidates for trabecular meshwork procedures, Schlem canal-based MIGS, or other canal-based procedures. Eyes who are responsive to SLT might have success with angle surgery. There's a study that was done that people who are responsive to SLT might have a response, and that's probably because they might have their outflow channels more posteriorly might be working a little bit more better in those earlier cases. Drop naive patients might experience the highest reduction in IOP. Consider going to surgery earlier rather than later. These are things I think about in surgery. And so I typically will offer MIGS devices and MIGS surgeries to patients earlier than I would a tube or a trab. So let's go into the nitty gritty, discuss a case, and then I'll have my esteemed panel give me all their amazing opinions. This is a real case. I have a 45-year-old patient. He happens to be an optometrist who has juvenile open angle glaucoma, diagnosed in his 30s. And his vision right now is fantastic. It's 20/25. His IOP off drops is very high, which is typical of juvenile open angle glaucoma at 36 and 28. He has had SLT. He is currently on 4 classes of IOP drops and methazolamide, and his pressure is 18 and 15. He has an extreme intolerance to all those drops. He's still on the drops because he needs it for his pressure, but he doesn't want to be on them anymore, and gets pretty extreme eczema and atopic dermatitis. He is myopic, and he wants to continue wearing a contact lens, and he very specifically does not want a trabeculectomy. And here are his OCT, and his field in the right eye shows a very small nasal step in the right eye. So Dr. McCabe, in this patient on 4 drops with a high IOP without them, complete intolerance, doesn't want to trab, what would you do for this patient?
Well, again, for me, it's my primary concern is the post-operative course for the patient. And I feel like this patient needs a bigger intervention than I want to do with my normal MIGS procedures. Although, if he absolutely said he didn't want any bleb of any sort, I might consider things like a combination of viscodilation, goniotomy, maybe even a MIGS device and ECP. But he is somebody I would send to one of my glaucoma friends and say maybe a Zen is the right spot for him.
Great. Anyone else want to chime in, or should I tell you guys what I did? You'll have plenty of opportunity to chime in. So I actually ended up doing, Nate, yes, what's up?
All I was going to say is this is a really tough case. So if there's any way that you actually manage this successfully, I'm already beyond impressed, because you're up against a wall. The patient doesn't tolerate anything. So even a lot of your options that you might think of as being pretty powerful, like tubes, most patients are still on drops after. So, you're really going to have to swing for the fences here.
It's tough. It was tough. And that's why I'm presenting this as a case to you guys, because it's still ongoing, but we'll tell you more. So this patient specifically came to me because he's like, I heard that you know how to do MIGS. I was like, I do. And they didn't want to trab. So I decided to do angle surgery for this patient. And looking at the options here, iStent and Hydrus, I would have to do with cataract surgery. He didn't have a cataract. He's a young patient. He's myopic and he wants to wear his contact lens. So that was really not something I wanted to do. And between Cahook and Omni, I decided to actually do goniotomy and canaloplasty for him to attempt to kind of, push things through that drainage system, open up and get some access. And I told them that this is probably something that may or may not work. We don't know. If this doesn't work, then we can do something else. And he was so happy to try this before anything else, because he was aware of all of the side effect profiles and the complications of other things. And here is a video of canaloplasty with partial goniotomy. In this particular video, you can see me inserting the guide wire for the from the Omni. You insert it all the way through, and then as you're retracting it, it is actually viscodilating. And then I did a goniotomy for him. Now, it was not partial for this patient that I did for this particular example. This is just the video, but I would go and do the superior part of the angle as well. And then you insert the guide wire. As you're retracting, it will viscodilate, and then you insert again. And then as you're retracting back, you can basically open up. You can see me going back and just unroofing the angle. Okay, so this is a very small amount. If you want more, which is what I did for this patient. So post-op day 1 is IOP was 7. It's amazing, it worked. We're so happy. I was like, I'm so happy you came to see me. We're all cheery. And IOP post-op month 1, IOP was 20. Did I also mention he has a massive steroid response? Like literally the guy puts anything on his face, he gets steroid response to his eye. So I had to manage him through that. I actually decided during this period to place Vimatoprost SR during the steroid response so that I can get a little bit of control without putting them on a topical IOP lowering drop and get rapid taper of the prednisolone. So that's what I did. IOP was 16 for 4 months. So we got 4 months of IOP of 16 off all drops, which is actually great. And I think it might have had something to do with the Vimatoprost SR. Then the IOP went up to 20. So he's creeping back up to where he was. So I started him back on preservative-free drops to see hopefully if that can kind of damper it down a little bit. And he developed pretty severe eczema again on this. And at 6 months, so 6 months after the Omni, his pressure was again 28. Really difficult to manage this patient. And I think I might have a question. Dr. Radcliffe, we tried angle-based MIGS and it didn't work. What would you do next for this patient and why? Oh, you're on mute.
Yep.
Yeah.
So, well, the first thing I would do is probably repeat the one thing you did that worked very nicely, which is that Durista. And I
right.
know what you're saying. You're saying, isn't it against the law to put in a second Durista? But in fact, it is not. It's just not on the label. So I will repeat Durista quite a bit. I usually like to let the first implant shrink a little bit, or I like to put the implant in the sulcus if they're pseudophakic. But I think in this case, you're up against a wall. I would repeat the Durista and try to get a second effect. But I know that's not what you really asked me. I also am sure the patients had SLT twice. So let's just take that one off as well. We don't have a superciliary device, and I think you've maxed out the benefit you can get from attacking the meshwork. So I probably would go for a subconjunctival filtration. Likely Zen here, although I'd have a conversation with the patient who's knowledgeable about whether he wants mitomycin around his eye. And if not, I would do some sort of Bearfelter clear path type 2.
Great. One other discussion that we had a lot before I decided what to do next is he was very concerned about the contact lens. He didn't want a trab because he didn't want the edge of the contact lens to rub up against the trab. And now we know with a Zen that there's going to be a very flat, diffuse bleb. I open up the conj, so my bleb actually tends to be a little bit more, tiny bit more raised. It doesn't look anything like a trab, but it's still a little bit more raised. So the question was, do we use a contact lens with Zen? And I asked everyone that uses Zen a lot, and I used it a lot, and they're like, oh, I never thought about that. Yeah, sure, let's use it. You can, that's what they said. So I gave him I said, I think that we can do it. So that's actually what we ended up doing was a subconj filtration, which is a Zen. And the two choices for filtration or subconj devices is a Zen, as we talked about. That tends to have a low lying bleb, especially if you place it ab interno. And that's really kind of key with the Zen. I will show you a video of me placing it ab externo. So it just forms a little bit more differently. And then PreserFlow, which is not an option right now because it's not approved, but it's similar in its design in that it's placed, part of it's going to be in the AC, part of it's going to be subconj, and it just flows from the AC out. It's a little bit larger lumen, and that is not out yet. So let's do this video here of me placing the Zen. So I place a stay suture and I evert the eye down, and I usually try to mark the eye, but in this case I didn't. So I insert a little bit of lidocaine into the area that I'm going to be working on. And then typically I will also do mitomycin at this point. I think in this particular video, I did the mitomycin at the end. I make a small, about a clock hour and a half incision, and I will dissect back. This is the absolute most important part of the step, in the same way that I dissect back for a trabeculectomy, because I want to make sure that I don't have tenons in the way. I mark the sclera at about 2.5 to 3 millimeters back. I insert the Zen stent, and being careful to see the tip of the needle. I then deploy and let go. And as you see the injector coming back, you have to be really careful, because even when the needle is 100% back, you have about 1 millimeter of stent still within the other part of the injector. So you just pull back very nicely. You can see the kind of the curl and the change of the shape of the stent. That's when you know that it's being hydrated. And then I measured it, and it was a little bit more. I want about 1 millimeter inside, 2 millimeters in the sclera, and about 3 outside. And then I dissect back. I make sure I lift the conjunctiva, and make sure there's no tenting. That's really also very, very important. Knowing that this patient is young and has robust tenons, I know that this is he's gonna have a robust reaction here. But I usually will do a 1 wing suture, making sure that the stent is in. I let go usually of my stay suture at this point. I use 7/0 Vicryl, and I do 1 buried suture, and typically that's all I need. So, and then I move the stent to make sure that there's some mobility. In this case, I did the mitomycin right at the end. And that's pretty much it. This is not of my particular patient, this video, but the next one that I show, I don't know what's coming up next is. So post-op day 1, the pressure was 6. We're happy again. Post-op month 1, it goes back up to 20. So you are right. This is a hard case. Massive, massive steroid response again. So how am I going to do a Zen? How am I going to do a trap? How am I going to do any of these without steroids for this patient? Rapid taper of steroid and the IOP is still high. And I think I might, Dr. Rhee might be up. Yes, he is. Why? Why is the IOP still high? And what would you do next for this patient?
Well, was the bleb, my guess is that there's too much fibrosis there. That might be because you have a new drain that you did there. And I commend you on your management of the case so far. It's pretty hard. One of the things that you could consider either at this stage or prior to the Zen is depending on how much angle you have left. Just had a case of this I did today. I'll let you know tomorrow how post-op day 1 was, but we had done a goniotomy in the past for about 100 degrees and it lasted many years for the patient, several years. So a little bit different than this case, and did a GAT using the illuminated catheter to get the rest of the angle. My hope is that since the angle procedure had worked before, that it would be beneficial for them now. Something you could think about, you could also pair, Dr. Radcliffe I know is a fan of combining MIGS, and he's published on that. One of the things that could be considered here too is a very, very mild, and there's a couple different ways to do it, mild cyclodestructive procedure, which seems heretical to me just 5 years ago. But you could do, the most gentle perhaps would be a micropulse diode laser. Another potential option would be a low frequency diode YAG. And I wouldn't necessarily favor going back in with ECP necessarily, because that's just the patient's phakic, and I think there'd be too much risk, at least in my hands, for trauma to the lens. You could do it, but I wouldn't necessarily want to give them a cataract per se.
Yes, tough case, right? I mean, and the patient's
great.
So knowledgeable. Thank you. I need the encouragement. So I sat here and I had, it was one of those like, oh, let me bring you back a month and let me sit on this. And I had to really think hard about what I wanted to do and whether I wanted to, what really I wanted to do. But before I get to what I did, we talk about why blebs fail, especially in Zen. And the first 3 thing is tenons, robust. It's a small thing. The whole job of tenons is to basically capture foreign bodies, right? And it sees something foreign and it's going to get attracted to it and it shuts it down. And bleb contraction is another thing, as you can see from here. And here in this video, it's, or in this picture rather, it's flat. It's like nothing was even never there. And other things to think about, why things fail. Lumen is not large enough. Maybe the pressure is too high and the physics of it is just, it's not enough. Obstruction of the lumen, iris, inflammatory material, cortex, if you're doing it at the same time as cataract surgery, or blood, that's enough. Remember, this is a very, very small little stent. So anything that could plug it can really cause failure. A steroid response causing such a high IOP like that I had. Oh, let me go back. This is going to be fun. Nate, listen up, buddy. So I talked about, and I wrote an article for Glaucoma Physician about tips and tricks for bleb needling. And this is how you can reduce IOP and prevent surgical procedures. So I looked it up on the internet so I can put a screenshot. And I thought, oh my gosh, I wrote the paper and that's definitely my name on there. But not only do I have 2 pictures of Nate Radcliffe, but I have 5 pictures of Nate Radcliffe on the one screen. So I thought that was pretty impressive and skilled that you can just kind of sneak that in there.
Wait, but are you in one of the pictures too, though?
I'm in 3 of them actually with you, but nice job. But this was mostly for trab bleb needling, which can be a little bit, similar and different. But I wanted to kind of bring that to people's attention and also make fun of Nate just a little bit, because why not? So bleb needling. And so in this case, I actually didn't want to give up on it. I felt like when I placed the stent in, I got pressure of single digits. This thing could work for him. So I didn't want to give up. And I saw total flatness. I couldn't see anything. So I actually revised it. I not only needled it, I took the conj down. And I took the conj down. And as you can see, this is why something like the Zen could fail in our patients. You can actually see, I'm going to see if I can point it out. The stent is right here. I'm cauterizing around it, really gentle, not to actually cauterize the actual stent. And I'm pulling off layers and layers of tenons right around it. And this is, within like 8 weeks, basically, of the patient. And you can see here layers and layers coming off. And then you can see the stent, it's actually curled. You'll see it a little bit better in just a moment. So I take that off. And if I had needled that at the slit lamp, I mean, honestly, I just don't think I would have gotten it in the right way. I placed the needle right underneath that curled Zen, and I lifted it up. And you can see it just kind of pops right out as soon as I can remove this. There it is. So it popped right out, and you can see the stent. So now I'm like, oh, great, I have it. I'm just going to check to see if there's flow out of it. I keep checking. I flushed it. I reverse flushed it. I could not get a single drop out of the stent. I don't know if it was collapsed on the inside. I don't know if there was something plugging it. So I just took it out. And you can see all this flow just like rush out of the eye. And I placed a new one right next to it, very cognizant of where the tenons was going to be. And I changed up my closure for this as well. So I place it again. You can see here, and this is the actual patient that I had. You can see the stent. I check to make sure that there's flow out of it, and then I close it up. But I close it differently than usual. I actually take a layer of tenons, which is cut out of this film for some reason at that one point. But you'll see it in a second. It's going to pop up. So I take the tenons layer, because now I've dissected it back, and I close that to create a plane so that hopefully there's not a new layer of tenons going towards my stent. And then that's the conj. So it's a 2-layer closure. And I thought that given this patient who doesn't want to bleb, you can see his durista is hanging out up there too, that I just do closure with a 7/0 Vicryl. And I think that's pretty much it for that patient. So how does he do? Oh, did I not put a slide for how he did? He did great. I thought I had a slide. Oh, I guess I didn't. Well, he did great. His pressure came down, and I just saw him at the 6-week mark, and his pressure is 14 off all drops. And I decided not to give him any steroids at all. So that's going to be fun. We'll see if that works out for him. But this was the last hurrah. I told him, I'm going to try this. If this doesn't work, I'm going to place a tube. And if the tube, then he doesn't want to trap. So I think the tube should be fine if that were to happen. But right now, at this point, it's working. So I'm really happy about that. I'm going to go on to our next case, 78-year-old female with ocular hypertension. Very similar. People with really high pressures like to come to my clinic. I am glaucoma after all. IOP is 35 and 30 on multiple topical drops. HVF and OCT is normal. Following intolerances, and Dr. McCabe, you're going to have a question coming up soon. So intolerant to timolol, shortness of breath and asthma. Prostaglandins give her redness. Brokinase inhibitors give her redness. Dorzolamide burns. Branded brimonidine is the only thing she can tolerate, and she refuses all surgery. So it's fun times in my office, I tell you. Dr. McCabe, all glaucoma drops cause some level of ocular surface problems. What features of ocular surface toxicity are the most concerning for you, and what do you do about it? It's a real question. I actually just asked questions I wanted to ask you guys.
No, it's good. I mean, there could be so many reasons, but obviously the more inflamed the surface is, the more involved the cornea is, the more it's affecting their vision, the more bothered the patient is, are really what bothered me more. Sometimes there's such terrible lid margin disease, even and lid surface disease, that of course, something more acute and contact dermatitis looking, like you can get with brimonidine is something you just patients can't tolerate that at all. So it kind of goes from the gamut of, yeah, they're a little red, to, gosh, their eye is just so inflamed they can't tolerate it. As a, for me, the quality of the ocular surface for their visual acuity is a big issue as well, because patients are affected in how they function with their vision. So I don't know what features, all of those things. I don't know that there's one particular thing that's worse than the next.
All right. Oh, I have a follow-up right away. Dr. Radcliffe, me. When is it appropriate to do SLT versus Durysta? Which would you do for this patient? And remember, patient doesn't tolerate drops and is really high IOP, 35, 30. No true glaucoma yet.
Yeah. So a couple things. I think SLT, has now been proven to be a very valid primary therapy and appropriate for ocular hypertension for the LIGHT study. I think Durysta has excellent data behind it. Interestingly, Durysta is very well tolerated by patients, and I would dare say better tolerated than the SLT procedure, but I still think SLT beats it on safety. So I tend to push or position SLT before Durysta in therapy, but if patients are going to need both, you can start to go back and forth between the two of them. I also would just make the point that Durysta is a medication, and it may be more advantageous for people with a low baseline IOP, where we know SLT tends to perform with those very high baseline pressures. That said, don't we all get a little nervous doing SLT on someone with a pressure, let's say above 28, because we do know you can spike after SLT, and that if you do, sometimes that can turn into almost a surgical problem, particularly in someone who doesn't tolerate many medications. So did you give me a high 20s or low 30 pressure for this patient?
A mid 30.
Mid 30. Gosh, I'd probably jump in with a gentle SLT, and I would hate to do lower power settings, but I think particularly if there's any pigment on the angle, you've got to back off. You may want to have some oral carbonic anhydrase ready, or you can do what I do, which is challenge asthmatics with betaxolol for a living. Not because I want to be doing that, but because I'm a desperate glaucoma specialist and I'm up against a wall all the time. I'm not really advocating for that, but if blindness is on the table, sometimes you've got to have a patient hold their inhaler in their hand, sit in your clinic for a day, and try just a single small drop of a beta blocker and see how their asthma does.
All right. So I actually, and I don't know if this is right or wrong, but this is how the story went. I actually decided to take her off everything to calm down her ocular surface. I gave her Durysta. This is a very short video. This is a patient who is supine, but typically I'll do it just at the slit lamp in the office, aiming down inferiorly, pressing the ejector button, and then it comes out so quickly. And you'll see right here, it's going to be circled. So it's very small and quick. Unfortunately, the IOP stayed in the 40s. Now, that's not good. So I decided that I was going to do SLT. It was unresponsive. In fact, you were right. Her pressure went up to 50s, and I learned this lesson, and it was a definite something that I'll never forget. So I started her back on her drops, gave her Diamox.
So we were both wrong.
That's right. So what did I do next? Yeah.
Can I ask a question though?
Yeah.
How, somebody who like this, who's just allergic to everything, do you have a little more hesitation in putting in, depot medication of any sort?
I didn't, because I felt like everything was so topical and surface related that it wasn't like systemic and really what intraocular side effects other than like maybe CME or a little uveitis. And honestly, in this patient, all bets were off. She probably may have been able to get that too. But yes, there's, I think that looking back, I probably should not have put a Durysta and just maybe tried the SLT just to see how she was doing. She still refused surgery at this point. I monitored her monthly with a pressure in the 40s or 50s, if you can believe that, because she just refused everything at this point. And she's like, well, I don't have glaucoma, so I'm not going to do surgery. And well, lo and behold, day 1, she had green OCTs. At month 6, she finally got RNFL thinning and a nasal step, and then she agreed to get surgery done. Ash, do you need to say anything? You popped up on my screen, but I don't know if you were trying to tell me something or not, but if I can keep going. Okay, awesome. All right, Dr. Rhee, when would you draw the line between a Zen versus a tube in a patient? And does the Tmax make a difference to you?
Not necessarily. I mean, I think both could be effective at the same pressures. The one thing I might, even though you didn't ask, I thought I could give a pointer. I think you did the absolute right thing, Sahar. It just, unfortunately, sometimes, right, it like in this case, didn't work out. But when you're worried about a pressure spike and you'd like to do an SLT, instead of doing 360, you can do 180. And the likelihood of, and then come back in a couple weeks and do the other 180. And you know, in other situations, SLT and Durista can be complementary, because the Durista works at the uveoscleral pathway and SLT primarily in the trabecular meshwork. But just outflow here in this particular patient, she's just pretty resistant. In terms of the Tmax, doesn't make necessarily a difference to me. Generally, I like to start smaller. So I think, you know, in your question, to answer your question, rather than between a Zen and a tube in this particular patient, I would try a Zen first, and then, you know, you've got the tube in the background. The other last thing I might mention, an older teaching, but I think it still potentially could apply in somebody who's contact lens dependent, a soft contact lens. A rigid contact lens, often paired with a tube shunt, might be a little bit safer than a trabeculectomy with a soft contact lens. Just something to think about.
Good. That's good. Great advice. So let's see what I did. I actually did a Zen. I did it ab externo, but I did it transconj for this patient just to show how that worked. So I marked the conjunctiva about 7 millimeters back. I inserted the needle very, very close to the conjunctiva, trying to be above tenons as much as possible. It's very difficult to do when you're at the 2 millimeter mark from the limbus, but you try your best. You can see here it wants to insert into tenons. I place it in, I use the stay suture, and I basically insert the stent. You'll see it in just a second, and then retract the needle back. And let's see, I'm gonna take a moment. I don't know why this particular video was slower here, but that's fine. We'll retract back the needle, and I can actually just fast forward. You can see it, there you go. And then you can see flow, mostly peritubular flow is usually what I see originally. And then at some point, I basically milk all that flow back, and you can see actually flow coming out of the site. And it looks like it may be coming right next to the tube or from the tube, I'm not sure, but something's working. And then just go back and I place mitomycin in these patients, and that's the end. And I just make sure I don't close that, it closes by itself, and then you milk it back, and hopefully you don't get any blood. This patient actually, the stent worked for 7 months for this patient. She did really, really well. The IOP went back up into the 50s at some point. I'm presuming that it failed for all the reasons we talked about. I ultimately placed a Barvelt tube for her. She then had hypotony and choroidals for about a month. And then she resolved, and her pressure is 12 with the Barvelt and a Zen and all the other things that I did for her. And she is doing well also. And I know that this was a MIGS seminar, but sometimes we do those things. And this did buy time for the patient. And it actually helped create a lot of trust with me because she was so anti-surgery that, you know, we said, look, we're going to do all these other things. We bought, you know, almost a year between all of the stuff that we did. And she's doing well now. Her other eye is really high pressure, and I'm trying to ignore that fact. But so let's talk a moment or two about the future of MIGS before we close out. I think the future of MIGS is going to be materials that don't promote tenon scarring if it's subconjunctival. I think that MIGS are going to be combined ultimately with sustained delivery, port delivery. This is a port delivery for retina, the Susvimo, but it's not obviously we don't have it in glaucoma, but it really should be headed that way. And then MIGS with IOP sensors and the ability to do 24-hour monitoring without having the patient come in for a pressure check. And in summary, MIGS, as we know, can be used for early intervention in mild to moderate cases. There are 3 types of MIGS that I talked about. The decision to refer for MIGS can be based on progression of disease, IOP, or the need for concurrent cataract surgery. And ultimately, you just have to customize for each patient. I mean, that's what I do. I think that I've tried to do as much as I can for each patient. These are 2 really complex cases because this was MIGS to the max, as the title of my slide showed. So I didn't want to give you anything easy, but one size does not necessarily fit all. You have to use your data, your own data from your surgeries, the anatomy of the patient, and the patient, him or herself, to help guide you with your surgical care. And with that, I thank you. And this is a picture of Hawaiian Eye from 2021. And that's it. Thank you guys for joining me.
Great cases, Sahar. That was great.
Amazing.
Thank you.
Sahar, that was fabulous. I think I learned the most out of this whole bunch. Obviously, I have one major question. And I think this is
Yes.
very, very naive for me to ask this, but being a non-glaucoma person, I can ask it, I'm guessing.
Yes.
So the question is, which of these procedures is probably the easiest to do versus the best result long-term? So that's the good marriage that everybody wants, right? I mean, the easiest to do, but with the long-term good results. If there's, and anybody can chime into that, huh? All the experts, please.
I mean, some of the, so like easiest to do for me is an iStent is the easiest to do, right? But I'm not going to do those in advanced cases. For me, the success in iStent and Hydrus, but really I use iStent more, is that I implemented early, a little bit earlier than, anything else. So early glaucoma, and I feel like they have good success. So that's as far as like easy. But honestly, I mean, I do a lot of Zen, and I think that I have good success now that I have realized how terrible Tenon's is. And if I can manage that, that's why I open up. And that's why my revisions, I typically open up, because I just want to get rid of it at that point. But, and then I have really good long-term results with those patients off of a lot of their drops. And I try not to give up on those procedures, because if it's failing, like I said, it's almost always from Tenon's, but you can kind of recover it. How about you guys? Anyone else have anything?
Yeah, I would love to hear others' opinion as well.
Sahar, the one thing I'll say just briefly about Tenon's is that I started taking it out when I do my Abex Zen to just create a Tenon's pocket. And it changes the blood morphology a little bit, and it gives you a little less to needle down the road if it does fail. But I do think it cuts back a little bit and gives you at least an area of ischemic blood.
That's good.
Yeah,
Yeah.
So
yeah, it's Sahar. I like your thinking. I agree with you. To answer your question, Ash, I agree with Sahar that iStent's probably easier to perform, but I think in terms of shifting that balance more towards efficacy, I think a Hydrus implant is really beneficial. The literature on that is pretty strong. There's a direct head-to-head study comparing the two, the COMPARE study. Again, that was done with 2 iStent classics, but in the basic science literature as well, which our laboratory performed with Carol Torres in collaboration with, the Hydrus actually did better in cadaver eyes than either of the iStent models. So, and the basic science or translational science often will predict the clinical results, at least with MIGS devices. So that might, depending on what you're looking for. And I completely agree with Sahar that those 2 procedures are more for earlier stage glaucoma. Although if you're taking out a cataract, it's not a bad thing to think about as well. And goniotomy, depending on your comfort with the anatomy, goniotomy can also be something that is technically easier to ramp up your skill set and feel expert at as well.
Got it.
Yeah, I was going to kind of say the same thing. I think that having, first of all, the skill to get a really great view of the angle is sort of the foundational thing to do an angle procedure. And angle procedures just tend to have less post-operative considerations and less risk, I think, as well. And so it's a nice place to start. And then if you're cannulating trabecular meshwork into Schlemm's canal, that procedure is pretty much the same, whether you're doing it to viscodilate, to do a goniotomy, or to put in something like that slides along it, like the hydrus. So if you kind of get that idea of how you cannulate, pass through trabecular meshwork and into Schlemm's canal, you have at least a few different devices you can use, even in combination, to get a better result without having to learn a totally different skill. So I think that kind of is the combination of ease of adoption with efficacy.
Got it. Thanks, guys. I think that was important. I think we had one. Yeah. What is the, when you talk about SLT, what is the, and this is again coming from the audience, probably have not done SLT. So what is the actual problem with SLT when it comes to in these complex cases? Where does the issue lie when you start to do SLTs? Anybody?
Are you
This is not
are you
directed
saying
to
you mean why does it cause the pressure to go up?
right, pressure to go up? Yeah.
Oh, okay. I think that it might be from excessive inflammation. That's my best guess, but I'm going to let the panel decide if there's something else. I think it is excessive inflammation and maybe kind of like a shutdown at that point because the pressure has been so high. I don't know. Anyone else have a little bit more detailed answer than that?
I don't think anyone knows, Sahar. That's a great answer. I don't know if anyone knows. With speaking from personal experience, I always make sure on gonio and Dr. McCabe mentioned the importance of gonioscopy intraop, but also in the clinic. If the angle's too narrow, then the inflammation from any laser, even SLT, can cause scarring and zipper it shut. We just published a paper on the mechanism of SLT, another mechanism of SLT, in which it looks like you get, when you hit the trabecular meshwork, you get loss of the endothelial cells. And then over time, the new endothelial cells come in and migrate into and repopulate that area. And so our clinical recommendation from that was, if you paint the area, then you kind of wipe out the cells that would ordinarily be nearby that could migrate in. So I think a technique point with SLT would be to separate the spots out, thinking or allowing for live cells to kind of repopulate into that. But we just published that a month or two ago. So it's not really
incredible. That's good.
I have a question. So for the postoperative IOP spikes with SLT, are you typically then, seeing patients right away after SLT, like the next day, or do you wait more of a week, or how are you, or do you keep them in clinic for a couple hours after? What's your typical?
I think that I've learned now that when they start out really high like that, honestly, anything over 25, I'll definitely check them 30 minutes after the SLT. I always do that. But for those particular patients, I would probably check them the next day or within the week at least, for patients who I think are risk for that. Now that I've kind of learned this, if they're just, mid-teens or high teens or low 20s, then I will do the SLT and bring them back in 6 weeks.
Okay. If they're more
IOP check.
You wait for the 6
weeks.
Yeah,
but in these like kind of high risk, like, multi-intolerant patients, I watch them a little bit more closely.
And then last question, do you have them stay on all of their glaucoma drops while you're waiting for the 6 week mark? Or
I don't. I probably should because, but I think I want to see what the actual laser does by itself. If they can be off of it and they're not high risk, then yes, I take them off everything. I do that for all my surgeries as well. I just take them off everything, watching them closely. Yes, it will require more post-op visits, but I need to understand if what I did has worked or not. And so I will typically take them off and then bring them back. And if their pressure is really high, then I'll restart the drops.
Got it. Thank you.
Got it.
Sure.
Folks, thank you so much. I know you've spent close to an hour now and more on this. I cannot thank you guys enough for being a part of this, honestly speaking. I would love to thank specifically the celebrity panel and Randy, if he's still around, I'm not sure. Of course, Sahar, you gave us so much in your presentation. It was such an interactive one and so much to learn from each of those procedures. You showed us, these complicated, tricky surgeries in terms of what to do in terms of decision making. And I think that's one of the key areas in glaucoma surgery these days. Which procedure has the advantages in what and what not to use in particular cases. Specific point which came up in many of your talks was the effect of tenon on the bleb-based procedures. And I think that's something that I personally will take away. Of course, a lot of the audience as well will, gave us so many aspects to think about before you go into a particular MIGS procedure. I think that's what really this whole presentation has covered. Of course, the most important point of all of this is the 5 pictures of Nate Radcliffe, which became the popular People's Choice Award. but that was key. And I want to thank everybody who's watching, for patiently listening and taking part in this discussion. We're really honestly humbled with the support we've shown, that we've got from the audience. We've close to about 3,000 subscribers on Rising Stars now. And, be following us on social media, Insta, Facebook, Twitter, on Rising iStars. The entire episode, honestly, will be available on our risingistars.com. That's on our website. So please make sure that you go there and also subscribe to our YouTube channel. I'd like to thank everybody now and signing off from the live event. Thank you so much, guys. Randy, thank you for being there.
Thank you. Bye, everyone.
Thank you, guys.